والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. Dear colleagues, distinguished colleagues and esteemed speakers, ladies and gentlemen, Assalamu alaikum wa rahmatullahi wa barakatuh. On behalf of the Saudi Society for Family and Community Medicine, it's my great pleasure to welcome you all in this accredited educational webinar with the title Redefining Migraine Journey from Recognition to Prevention. I'm Dr. Ashraf Amir. I'm a consultant in family medicine in the International Medical Center and a deputy head of the Saudi Society for Family and Community Medicine, Jeddah office. So before I start, I just would like to set the stage and pave the way by saying that migraine is more than just a headache. Many of us, we think that migraine is headache, but it's beyond headache. Why? Because it causes some kind of disability and affects millions of people across the globe during their most productive years. And in fact, despite the significant impact on patients and family and healthcare system, migraine, unfortunately, in the primary care centers, still under-recognized, under-diagnosed, and often undertreated, especially in the primary care and in other sectors as well. And most of the patients first seek medical attention late after many years of suffer. So today, our programs has been carefully designed to bridge the gap. So we will follow the patient's journey from the recognition of the diagnosis and the pain to the early clinical features of the migraine to establish an accurate diagnosis and then implement the evidence-based migraine management strategies and exploring the latest advances in the prevention and of prevention therapy, including the role of the anti-CGRP treatment. I'm honored, ladies and gentlemen, to be joined by two distinguished experts in the field of migraine. Dr. Saeed Al-Amoudi, he's a consultant in family medicine at the International Medical Center, who will discuss empowering early migraine diagnosis and management in primary care. This will be followed by Dr. Hisham Al-Dafair. He's a consultant neuromuscular neurologist at King Fahd Medical City in Riyadh. And we will provide valuable insight into evolving role of the anti-CGRP therapies in migraine management. So I would like you to extend our sincere appreciation to AbbVie for supporting this educational initiative and to the FEXS ملتقى الخبرات لتنظيم المعارض والمؤتمرات for organizing today's event. Most importantly, thanks to all of you for dedicating your valuable time to continue the professional development and improving the care of patients for those who are living with migraine. I encourage all of you to participate actively and to share your experience and engage yourself with a lot of discussions at the end of the sessions. And we'll be able, inshallah, to answer the questions at the end of the two presentations. So thank you for all of you for joining us. And before that, I would like just to talk a little bit about the journey of patients of migraine. I'm not going to present any slides, but I'm going to highlight the most important steps of the patient migraine in the primary care. So when we talk about the migraine journey, it refers to the entire patient experience from the first biological changes that triggered the attack throughout the diagnosis, treatment, and then to the long-term preventions and the quality of life. So this is constitute the journey of the patient through the very long distance of the spectrum of migraine experience. And of course, when we look into the first attack, before the first attack, usually patients, they have some kind of risk factors, like they belong to family histories, who have certain members of the family, they have migraine attack, female gender, hormonal fluctuations, sleep disorders, and stress and anxiety. All of these are constituting the risk factor for the migraine. And of course, as you know, there is certain phases for the migraine, like a prodromal phase, and then the aura, and this will be followed by the headache phase, which lasts about 4 to 72 hours, and finally the postdromal symptoms, which is the migraine hangover, which lasts for almost 24 hours to 48 hours. So when we talk about the diagnostic journey of the patients, unfortunately, there is a delay in the journey, in the diagnosis of patients. And many of the patients, they seek certain remedies by their own, or they go to seek physicians who don't diagnose them right on time. And ultimately, this will delay the presentation of the migraine and predispose the patient to have chronic migraine. The other issues here in the journey of the patient, the misdiagnosis. So patients with migraine, they misdiagnosed to be sinus headache, tension headache, and cervical pain, and so forth. And multiple physician visits before receiving appropriate treatment. This is the most common encounter and most common observation for patients with migraine. So diagnosis is clinical using the international classification. Very important for all of us as a primary care physician to accurately diagnose the patient with migraine, and this is saving the time and saving the efforts and the resources to identify patients in first attempt with the presenting symptoms. So patients usually trend in the first time to use certain self-remedies like over-the-counter medication, analgesic, and certain herbal medications, and then they tend to go to the primary care physicians for diagnosis. And here comes the role of us to diagnose and to educate and to initiate the acute treatment and the lifestyle modifications. And then the patient will be referred to the neurologist in the secondary care, where there will be the management of the patient throughout the spectrum of acute and chronic, as well as the prevention of migraine attack. And the neurologist, even they can manage the chronic migraine and the treatment failure, and they can manage the adverse therapies as well. But later on, the patients will be going from back and forth between the primary care and the secondary care. And ultimately, we have to make sure that the patient is diagnosed right in time and to improve the quality of life patient, because those patients are usually become dysfunctional. They cannot perform, and they have less productivities, and they are also associated with certain presentation of mental disorder like depression and anxiety and so forth. So this is, in fact, the journey of patient with migraine, starting by treating himself and then going to the primary care, and then ultimately going to the secondary care where he's seen by the neurologist. But here we are working in an era where we have to implement the multidisciplinary team approach. So the patient has to be managed by multiple members of the professionals, like the primary care physician, the family physician, the neurologist, the psychologist, nutritionist, educator, and so forth. So this is why our service should be addressing the patient in a patient-centric approach, so the patient would be handled carefully to improve the quality of life and to alleviate the consequences that disturb the productivity of patients and make the patients disabled. So this was a brief introduction just to highlight the journey of patient throughout the spectrum of migraine. And now I would like to welcome Dr. Saeed Al-Amoudi, who is a consultant family medicine from IMC. He will shed a light on the second topic. So I would like just to welcome you, Dr. Saeed, and I would like to leave the floor for you.
Thank you so much, Dr. Ashraf, and good evening, everyone. Thank you for this, for the setting the scene and explaining the burden and the patient journey. So, inshallah, now I will share my slide with you for the clinical and practical pathway that we can use it in the primary healthcare, so we can diagnose the patient early and treat it effectively. So, is the slide shown now?
Yes, we can see it, but make it full screen,
Okay.
please. Full
Uh,
screen.
yeah,
Yes,
no.
yes, that's good. Go ahead.
Thank you so much. So, this what happened when, as you mentioned, Dr. Ashraf, when the patient is not recognized early. So he will be mislabeled by sinus stress tension headache. This will lead to undertreat the patient with low doses, late treatment. This will lead also to overuse and frequent analgesic use. And at the end, the patient will reach the chronification and will have the disability. So to break this, we need to early diagnose the patient and early recognize the patient. So we can change this conversation from repeated painkiller to understanding the pattern, treating early, and preventing disability. So this is what we will do in this presentation. The first part about the diagnosis, we need to safely screen the patient and to have active positive diagnosis because the migraine has criteria, not diagnosis of exclusion. So this is our pathway. First, we will talk about the safety screen, the red flags, the examination, and of course, this is incomplete with the full history. Then the diagnosis for the migraine with the ID migraine screening and ICHD criteria. We will see why we need to measure the burden. Then we will talk about the treat of acute attack and to prevent the disability. So I prefer to start with this slide, which is about the mnemonic Snoop for slide. This is to see the red flags that could have and could alter our pathway from usually primary headache to something more serious need to be investigated. So for any new, changing, or atypical headache, I use this SNOOP 4 criteria. Is for systemic symptoms if the patient have fever, malignancy, immune compromised, or pregnancy or postpartum. The N for any neurological deficit, the two O's for the onset if it's sudden, and for the older age if the patient tell me that the headache, this is the first time to have it and his age 50 or above. For the P's, we have if the patient have a change in the pattern, progressive, positional headache, or if the headache is precipitated by cough, exertion, papilledema, painful red eye, and all of these, if any of these present, then the patient could leave the pathway of usual migraine headache to investigate for secondary headache and to rule out other serious cause. Usually, it is really important to ask about, for every patient, to ask about trauma. If the patient have a history of trauma, this is really important. So after we excluding that in the history and with the context, with the full history, we will go for the focused examination. It seems it's difficult, but actually even in primary care setting, you can do this in few minutes and to just differentiate between patient need urgent care or a patient usually comes with primary headache. So we will start with the general appearance, if the patient look toxic or not. The vitals are really important. Here we have three things need to be assessed: the eye examination, pupils, extraocular movement, the fundus, a neuro exam, including the motor function, sensation, reflexes, gait, and of course the mental status and cranial nerve. And for the head and neck, I need to see if there is any signs of meninges, temporal arthritis, if there is any TMJ. All of this full examination will help me to differentiate between two pathways. If the patient have typical migraine history, normal examination, and I need to confirm the diagnosis, or if the patient have atypical finding, and in this case, I believe the patient needs further investigation, referral to the emergency or to the neurologist. So how we will differentiate that? I will try to be practical as if I am in the clinic. So I like the traffic light approach. Here we have three categories. The red means the patient need to be referred to the emergency at the same time, immediately. Why? If the patient have thunderclap or the patient described this headache as the first worst headache ever, if there is any motor deficit, if the patient have seizure, confusion, fever, toxic appearance, or signs of meninges, the papilledema or acute painful red eye, if the patient is known to have cancer or immune compromised with a new headache, or if, of course, if the patient pregnant or postpartum with severe new onset of headache, all these patients will follow the acute stroke secondary headache pathway first. So we need to exclude other secondary causes in this case. What about the orange? This means the patient need to be evaluated urgently in few days, 2 to 3 days. If the patient have a new headache onset after the age of 50, if the patient have progressive substantial pattern change, if the patient complain of headache that increase with the exertion or the position, if the patient has unusual, prolonged, or persistent aura, or of course, if the patient have a recurrent but established atypical aura, I believe these patients need to be shared to have a referral to the neurologist for further assessment. So what about the green? The green likely this represent the primary headache, and this is the pathway of our migraine patient. If the patient is stable and have recurrent pattern, if he meet the migraine features, and we will see that, if there is no red or orange flags, and have normal focused examination with established typical aura, this will goes with our pathway. So if the patient comes in and this is, yeah, this is important message. If there is any new or uncertain onset of aura, this is not usual aura, need to be careful about it. So if the patient is stable and the normal examination is normal, the full history is suggesting migraine, no red flags, this is a tool for screening. So we can ask about three things: disability, nausea, photophobia. If the patient answer yes of two of these questions, this increases the likelihood of migraine diagnosis. So we will go to the next step for the criteria. Sometimes it's difficult to remember the criteria. Keep it at your desktop at your clinic to review it with the patient if the patient have really migraine. So for the migraine without aura, we need to have at least 5 attacks. The attack, if untreated, will last from 4 to 70 hours usually. For the pain, we need at least two pain feature like unilateral, pulsatile, moderate to severe, or worsened with routine activity. Also, I need to have associated feature like nausea, vomiting, or photophobia, phonophobia. Also, not better explained by another diagnosis. So these the 5 elements for the diagnosis of the migraine according to the ICHD3 criteria. So what if the patient comes with aura? The criteria here will be at least 2 attacks with fully reversible aura symptom. And this is really important because the patient should have a complete reversible aura. Otherwise, there is something need to be investigated or dig more. The diagnosis of the aura will need 3 of 6 characteristics. If the patient have gradual spread, because aura usually like this. Also, if there is 2 symptoms happen in succession, one after the other, each lasts from 5 to 60 minutes. Unilateral with at least one positive symptoms like flashing light, or if there is tingling sensation, and not more than, and the headache accompanies or follow within 60 minutes. So it can be with the aura or after the aura. And of course, not better explained by another diagnosis. So this is for the criteria of the ICHD3 criteria. So the most important question now, is this aura or could be a TIA or stroke? So there is no solid or يعني, rule to differentiate between the two. But here we can suggest this goes more with aura if the patient describes the onset as gradual onset. It happened in succession as in the criteria, have a positive symptoms, not all negative symptoms, if the duration between 5 to 60 minutes, and the recurrent or stereotyped evolution. This goes with the aura. On the other hand, the TIA or stroke will happen sudden, simultaneously, negative symptoms only. The aura could last for more than 1 hour. And of course, if it is new or uncertain, so this is not a recurrent usual aura. In these could help to differentiate between the both usually, but you need to see the patient as a whole also. And also, you need to look for the red flags that we discussed before, and also for the migraine feature like nausea, vomiting, photophobia. All of these need to be assessed for the patient. Here, the common mimics, and here the message is to look for all the symptoms together, because tension headache usually bilateral, but migraine also can be bilateral or pressure-like headache. The cluster headache, which is comes in short and excruciating unilateral orbital or temporal pain, because the management plan will be different. Sinusitis, usually with infectious course, fever, purulent discharge, but again, migraine can cause nasal congestion with other migraine feature. TIA and stroke as we discuss it now. And of course, the medication overuse headache. This is something to be screened, and we will talk about it. At least the patient will have at least 15 or more attack or more day of headache migraine for per month, plus regular medication use and for duration for more than 3 months. Usually, or it could be the patient have both coexisting together, the medication overuse and chronic migraine headache. Now, the question is, when to investigate, and is it necessary for every patient with migraine? The answer is if the patient have typical stable migraine with normal examination and no red flags, so no need for further neuroimaging. Even for the reassurance, because a lot of time we do that to reassure the patient, and this is wrong. This is over investigation. We need to investigate when there is unusual, prolonged, or persistent aura, if there is any red flags that we discussed before, or the patient has motor deficit, not the usual migraine headache, here we can rule out other secondary causes. So this was the first part of the lecture of the presentation, to diagnose the patient and to rule the red flags. So now we will move. I have the patient, I did the criteria, and this is migraine. What I should do next? So here we will measure the burden to treat the attack. And why we assessing the burden of the migraine? Because we could have two patients with 4 attacks per month of migraine, but the disability will be different. Some patient will do his usual daily activity, and the other could have very severe disability. He will misses his work. It will affecting his usual daily activity. So they are not the same. So we need to assess the disability and the frequency both, because they are not the same. Revealing the impact, it will guide the intensity, and after that we can use this for the follow-up, as we will see. So for the frequency, we will use the diary. This is an example. I don't need very informative information, a lot of information from my patient. I need only to have the headache days per month, migraine days, acute medication days, the attack duration and the response, and if there is any triggers known by the patient. This will make it easier for me to adjust the treatment and to follow up my patient. So as in the example, if the patient provide that he take the ibuprofen 400 but late, so the headache was the response was partially response. Then after that, on Thursday, the patient have photophobia, start the somatriptan early, the pain-free after 2 hours. So this will adjust my treatment and will give me the information that I need. So first, we need to do the diary, and we have both choices. We can use the paper diary or the app. This will be according to the patient preference. What I see actually in my clinic, a lot of patients, they prefer the app because it's easier, more convenient, and they just choose between the answers. So I believe it's better for our patient and better for me to follow up and to extract the data. But still, this is the patient preference. So now we have the frequency. We know that. What next? I need to measure the burden. We have 3 main questions. If I will start usually with my patient by the migraine days. How many attacks? This give me a hint about the frequency and the pattern. And also I ask about the medication days, because this will increase, if the patient is using many medication, this will increase the risk of medication overuse headache. And the lost days for the impact. And here, for the impact, we have 2 scores. You can use any. The MIDAS, which is the Migraine Disability Assessment Score. It contains 5 questions, we will see that. And the HIT6 score, which is for the headache impact test 6. So these two can measure the disability. The difference here is that the MIDAS can assess the disability over the period of 3 months. And according to that, I can make the invisible disability something countable. So I can see that from 12 to 20, usually this is a moderate disability. More than 21, this is a severe disability and will affect my decision later. The HIT-6 is a quick impact score. It measures the disability over the last 4 weeks. Usually, it's easier to use at the clinic when there is a busy clinic. According to that, we can have the little or no impact, some impact, substantial impact, or severe impact if above 60. So now we have the frequency, the burden impact, and we need to match all of this to the patient context because the patient comorbidities can affect my choices. If the patient have depression, anxiety, for example, insomnia, asthma, COPD, because sometimes there is contraindications for the treatment. The trigger context also can help to adjust the proper treatment for the patient. And of course, the medication safety, if the patient have renal, CVS risk, and if the triptan vascular caution is there, if the patient trying to get pregnant. So all of these together will help me to decide. So what after that? Now I had the data for the diary, from the diary, the burden, the comorbidity, context, and safety. So in my clinic, this information now will help me to choose the appropriate treatment for my patient accordingly. And it need to be individualized for each patient. Practical interpretation, I would say, if the patient have low frequency with low disability, here I need usually to optimize the acute treatment. If the patient have low frequency but major life impact, here I can discuss also the prevention for this patient. And of course, the frequent medication used to address the safety and overuse risk. Now, this is our menu for treatments. Here, I have, if the patient have mild to moderate attack, I can use the paracetamol NSAID. If patient have more severe attack, I can use the triptans or combination strategy like triptan NSAID or triptan paracetamol. I need to be careful about the nausea and vomiting because here I can add the antiemetic and also to adjust the route because sometimes the patient cannot take oral treatment, and this is really important for the treatment of the migraine. And of course, we have the newer acute option when triptan fail, not tolerated or contraindicated, or for some patient can be started, the G-band and the DTAN, and I believe this will be discussed in detail with Dr. Hisham, inshallah. And if the patient have need rescue or emergency pathway, patient have dehydration, confusion, here we can refer to the emergency pathway. How to put that in a prescription, from option to prescription. To make everything clear, first, we need to ask ourselves, is this usual migraine? No red flags, normal exam? So now I will put the criteria. Khalas, I know this is migraine. I need to see if mild to moderate or moderate to severe to choose the treatment. Ask about the vomiting, and if you need a rapid escalation for non-oral treatment, triptan contraindicated or fail, or I need to start the patient on G-band or DTAN. Also for the frequent acute use or disability for prevention of medication overuse headache plan. So what is the medication overuse headache? Usually we use the ICHD3 criteria if the patient have at least 15 days per month, and here we are talking about the days of headache, not the tablet, plus the regular medication use, plus the duration more than 3 months. If this happens, so the patient now is labeled by medication overuse headache for paracetamol and NSAID more than 15 days per month, for the triptan, opioid, or combination treatment more than 10 days per month for the 3 months. Here, at my clinic, I find it practical to go safer and more conservative with the recommendation of the International Headache Society of 2024. They advise not to exceed 9 days per month for the NSAID, DTAN, and analgesic like paracetamol. Also, not more or less than 8 days per month for the triptan and combination therapy. This is for safer practice, but still, for label the patient with medication overuse headache, I will use the ICHD3 criteria. So, until now, we talk about the diagnosis, the acute treatment, but now we need to move for the prevention and the future disability, how we can deal with that. This is the part 3 of my lecture. So when should prevention enter the conversation? For sure, if the patient have more than 4 attacks per month of headache days, this at this time I can start the conversation, but this is not a solid or cutoff that I need to just have it because some patients have very significant affecting their life. So I can go earlier or less than that. Also, if the patient, I know this acute treatment is ineffective or unsuitable or poorly tolerated, then I can discuss also the prevention. Of course, if the medication are used frequently or overuse risk is emerging, here I can start the prevention. And the patient preference, this is really valuable for our management plan. What is the patient preference? Is he need prevention treatment or not? And of course, if the patient have chronic migraine, substantial functional impairment, this strengthens the indication for the prevention. So what are the options? Here, just to have a look over the option that we had, the beta blocker sometimes it's very suitable. And again, according to the context of the patient, if the patient have hypertension, for example, beta blocker is a good option. But be careful if the patient have asthma, bradycardia, and hypotension. Also for the topiramate, if the patient have a weight concern, but avoiding pregnancy or watch the cognition could affect the cognition, and if the patient have history of renal stones. Amitriptyline also with the patient with insomnia, tension type overlap, but be careful about the side effect, anticholinergic effect, the candesartan, vanilla vaccine for patients with hypertension or depression or anxiety coexist, and of course the valproic acid, but this for very selective patient, and I believe need to be with shared management with our colleague in the neurology for selected patient. Also, we have the chronic migraine and targeted therapies like Botox, the CGRP monoclonal antibody, and the oral G-band can be used in prevention these choices. And we will see, inshallah, the evidence, I believe, with Dr. Hisham, inshallah, they are very effective. So after that, if the patient start the preventive treatment, how can I say if this is a failure or not? It is really important, and this is really a practical point to have the duration because I cannot judge before the 3 months. 3 months, I think, is a suitable duration at the maximum tolerated dose before I declare the failure. If there is a 50% or more improvement, this means the patient have a meaningful improvement. Some patients with difficult chronic migraine, even the 30% will be clinically valuable. But before declare the failure, ask 6 questions. Is the diagnosis correct? You need to review it. Review the dose, the duration, the adherence of the treatment from the patient, if the medication overuse is there, or if the patient have expectation that not be reached yet. So at that time, I can say that this is a failure and I need further adjustment. Also, as with the acute treatment, the context is very important. I need to check for the reproductive safety, cardiovascular, and the context and adherence for the patient. All these will help me to choose the best preventive treatment. What about the lifestyle? This is the most important thing. We need to adjust it according to the patient need, because I will not make the patient feel he will not have a normal life. Everything is restricted. I need to have specific tailored management with my patient because not all triggers could be the cause. Sometimes I know my patient, he have a sleep problem, he have a hydration or heat problem. So I need to discuss that specifically with my patient, the caffeine intake, start gradual exercise, stress regulation. Sometimes you need to have to refer your patient for CBT or control the stress. This is really important. And of course, the trigger strategy. Do not create a fear from the normal life for the patient. So we talk about the diagnosis, acute treatment, prevention, and now for the follow-up, how to reassess my patient. How could I do with my patient when he come back to me? So at the follow-up, I need to ask 5 questions. The 5 question is as the following. How many migraine frequency or how many migraine days for the patient? How is he doing with the disability? How his work? How his life? How is his lifestyle in general? Acute medication use and the risk of medication overuse headache, the effectiveness and the side effect and safety for my treatment, and the patient goal or the patient expectation. All these should be assessed at the follow-up because it is not about the pain intensity alone. That's why if the patient have a failure, we need again to see for the correct diagnosis, adherence, adequate trial duration, and the medication overuse. After that, I have 4 pathways or 4 action. If the patient is doing good, I can continue on the same preventive treatment. Or if the patient improve but still not at the goal, incomplete recovery, here I can optimize the treatment. Or if there is ineffective or poorly tolerated, I can switch to another class. And of course, if I can escalate the treatment and go for the CGRP or Botox injection, these 3 actions will be after the assessment at the follow-up. And also ask again if the patient need to investigate any red flags, ask if the patient need a referral or to escalate the treatment as we said. So putting all that together in summary, if there is one slide to remember, this slide. First, I need to take a full history, full examination, screen for secondary causes and red flags. Then I will go to the diagnosis of the migraine with the criteria. I need to measure the burden by the frequency, the diary, and the disability and the context of the patient. Then I will treat the acute attack and I will discuss the prevention if needed. And after that, we will close this loop with the reassessment to optimize the treatment. So this is my last slide, and the last message is migraine outcome improve when we diagnose early, treat effectively, measure the disability, and reassess before the disease become chronic. Thank you for your attention, and was my last slide. Thank
Thank
you.
you so much, Dr. Said, for this wonderful presentations. You have highlighted the full journey of the spectrum of migraine through the diagnosis, the treatment, and even the follow-up. And you have highlighted the secondary causes of migraine elegantly. And finally, you have summed it up with a lot of clinical and practical tips, to put these kind of evidence in the real world practice of our clinical setup as a primary care physician. So thank you so much for your wonderful presentation. And now, ladies and gentlemen, we'll move to the second guest speaker, whom we have been honored to have him with us here today, Dr. Hisham Dakher. He's a consultant neuromuscular and neurologist in King Fahd Medical City in Riyadh. He's going to talk about the role of anti-CGRP in migraine management. And it's always nice to have both primary care and secondary care getting together in this kind of scientific gathering in order to highlight the full spectrum of the disease in between the two level of practice. So without any further ado, I would like to leave the floor for Dr. Hisham, and I would like to thank you on behalf of all the audience, Dr. Hisham, for accepting our invitation and being part of this wonderful gathering.
Thank you very much, Dr. Ashraf. I'm terribly sorry because I'm having a lot of technical hiccups here. I'm literally doing it from my mobile as we're speaking.
Oh.
I'm trying to just share the screen with you guys. My computer just went bad on me. Are you seeing my screen?
No, we cannot see it, Dr. Hisham.
Just give me 1 second. Hopefully now.
Yes, we can see it.
So without further delays, thank you very much for the introduction, Dr. Ashraf. Is it clear now, my voice?
Yeah,
And
yeah, it's clear. But if you can put the
perfect.
full screen, that would be better.
Oh, definitely. Thank you for. Mm, do- do- Sorry, I'm trying to do it. This is my first time doing it from my phone. Okay. Uh, is it showing now?
Not really. No. What I'm gonna do is let me see.
Okay. Is it better now? Now I think it's clear, right?
Yes.
Okay, perfect.
Okay.
So I have just a quick disclaimers. This is organized by AbbVie, and but it doesn't affect our clinical and scientific insights. And I have been a speaker and moderator for several other pharmaceutical companies. So we're going to be talking about a couple of things here. I apologize, I couldn't listen to the whole first lecture. It was choppy, my connection. But if we're going to be talking mainly about the GPANs and the new era of the migraine therapy. So we're going to talk about first about the barriers to care. I just want to highlight that people with migraine grade 2 or more, meaning they're having minimal disability requiring treatment, basically. They usually have three barriers in order to get to good treatment. Number one, the medical consultation sometimes is a barrier for the lack of specialists or otherwise. Accurate diagnosis and appropriate treatments, they remain the barrier. So after these three barriers that traverse all three, one study showed that only 15% of migraine patients did that. Uh, and then now moving on to the migraine treatment landscape. So the migraine treatment landscape, we always looked at the number of days of headache per month. I don't like to remark it as how many episodes or how many attacks per week or per month. It makes more sense to make it at headache days per month. And I always tell my patients the treatment is by three ways, treatment of migraine. They always go hand in hand. The first one being the acute treatment medication, and we always encourage to take it as soon as they feel that the aura or the migraine attack itself is coming on. The second is the preventative therapy, and the goal is to reduce the frequency, severity, duration, and disability. And third, which is extremely important, and I want to highlight for everyone here, is the lifestyle modifications. This is one of the least looked at strategies, in my opinion, seeing migraine patients. You need to check on basically three things. Hydration, they need to drink 2 to 3 liters of water per day, sleep hygiene, and routine in eating and sleeping, and exercise. But hydration and sleep, probably if you fix those two, I guarantee you're going to reduce their frequency and severity. The migraine pharmaceutical landscape, basically, we have basically acute treatment, which are the CGRPs, the Opelgepant, the Rimegepant, Zivegepant, and then we have also the Ditans, which came in the 2019 or so. And then the preventative treatments, we have them classified as conventional, and the newer ones, the monoclonal antibodies, and also the Japans, as well as the tinobotulinum toxin A. How do these medications work? Because I always mention to my patients whenever I prescribe those medications that those are not painkillers, and those are very specific to migraine. So the triptans, they basically do something a little bit more generalized of blocking. It's a 5-HT receptor agonist, and it blocks presynaptically the CRGP release. However, when that occurs, where the basis of the migraine occurs, which is the trigeminal nucleus, this will affect the smooth muscles as well, and this will affect cause vasoconstriction. That's why we have a little bit of concern whenever with the cardiovascular risk factors and triptans. Then the GPANs, or the newer molecules, those have basically no vasoconstriction. Why? Because as you see here, I'm trying to find if I have a pointer or not, but basically, as you see here, it basically blocks the CRGP from connecting to its ligand, or the monoclonal antibodies would block the CRGP itself. So the abortive and the migraine landscape. So the acute treatments, basically we have general analgesics that are not specific for migraine, as I said, combination OTCs such as solpadeine or NSAIDs, naproxen, whatever have you, and the acetaminophen. And then we have the migraine acute treatments, which have changed over times. In the 1930s, the ergots were something very popular, but now it's never used because of the severe side effects that they have. The triptans were in the early 90s, and they were some kind of a revolution because they were the first migraine-specific treatment with less side effects compared to their previous ones. And more recently now, from 2019 and upwards, we have the DTANs, which lamotrigine is one of them, but that causes drowsiness because it crosses the brain-blood barrier. And then we have also the GPANs and the CRGP monoclonal antibodies, which came around the 2018 to 2020. Moving forward, we have to have a tailored approach to migraine treatments. It's not one size fits all. For example, opioids and barbiturates, they have limited efficacy and risk of dependence. We never use that. We have ineffective acute treatments which are associated with risk progression. Then we have also a lot of switching that happens in migraine patients among different triptans to change to find a better effect. And the triptans, we know they're contraindicated in certain patients with cardiovascular risk factors. The non-steroidals, they can cause ulcers, and it can, we don't like it a lot with patients who are taking anticoagulants, especially dual anticoagulants. And a lot of acute therapies are not they're not allowed in pregnancy and breastfeeding. So the American Headache Society consensus statement that the GPANs have an established efficacy, along with the triptans, the combination analgesics, all those things. We know other medications that are probably effective. They are probably effective because they have not been studied prospectively, especially things like the metoclopramide, but we know that they are class A level of evidence to use, especially in pregnant ladies. However, now talking specifically about the GPANs, the American Headache Society consensus statement that it's appropriate to use when all of the following are met. It's recommended by a licensed clinician. The patient is at least 18 years of age, and the diagnosis is made of aura, migraine with aura, or migraine without aura, or chronic migraine. And one of the following, either contraindication or intolerability to triptans, or inadequate response to two or more oral triptans, or either of the following, if it's clinician attestation that the patient needs the medication, or validated acute treatment reported outcome that had not met its intake. The European, they do it in a little bit different way. They would called it, basically they would evaluate the triptan, and there is they would use it for triptan resistant, which are two or ineffective triptan failures or triptan medications that have failed, and they define the failure as an effective that the improvement from a headache is significant enough, and it has to be effective in 3 out of 4 consecutive attacks. So if you have, let's say, 2 attacks that have not completely resolved, it's considered ineffective. Moving on to the triptan failures and the medication overuse headache. This is, if we know that this is a study that showed that a good number of patients, they have ineffective treatment of a single acute attack using their triptans. So even when you ask them how is the medication, they say, well, it's okay. It's not like it's magic. It works. Sometimes it doesn't work. That's not the case for all patients, of course. But as you can see in this study, the first intake, for example, had 3 failures in 8 different subjects, and the second intakes had 3, and the third intakes had 4. So out of 4 patients, 4 are non-responders. So that's not a small number. And the triptan cycling and the migraine-related costs, there's a study that had showed that it actually perhaps costs more than moving on to something different than a triptan. And the other thing is that clearly the triptans have an issue with non-responders, the intolerability of it, the medication overuse, and the cardiovascular contraindication in certain people. So the medication overused headaches, it's defined as the headaches in an individual who have a pre-existing headache with medication overuse, and they develop a worsening of their pre-existing headache, and they need to meet the criteria of a headache occurring at least 15 days per month for more than 3 months, and no other better accounted for diagnosis. The clinical importance here I want to highlight is that almost half of our chronic migraine patients that we see in the medication and the clinic, have a medication overuse headache, and perhaps even more, I would say, in my anecdotal experience. Many individuals will not improve after the medication withdrawal, and that's why they end up in medication overuse. And individuals who are meeting the chronic migraine and medication overuse should be given both diagnoses. I see a lot of people who are hesitant about not putting these 2 diagnoses, but you can't fix the headache if you don't diagnose it very well. So talking about the gepants, the new acute therapies, the gepants are probably the hottest topic right now in the treatments of migraine. They are basically anti-CGRP receptor antagonists. So as I showed you in the image before, it means that it goes to the CGRP receptor in the postsynaptic trigeminal nucleus, and it blocks the receptor. So the CRGP will not be cascading the migraine play, and in the same way, it doesn't cause vasoconstriction. And unlike the triptans, as I said, they don't cause vasoconstrict. So far, we don't have medication overuse headache evidence for it. I don't know if that's the case in a few years to come. The appropriate treatment option for triptans non-responders or individuals who are unable to talk triptans, and all those are triptan contraindicated. And personally, I think, to me, I sometimes would go for the gepants as a first-line therapy, even if the patient has not failed. I wouldn't wait for them to fail a triptan in order to prescribe this. If they can tolerate the medication financially, or they have insurance. And just to highlight also, the triptans themselves, they're not cheap. When I'm saying this, The triptans are quite expensive, even though the label will have a different price tag, but a lot of the triptans, they only have 3 or 4 pills in it. So don't be fooled by just the small little difference in price tags. So the first, the medication that we're going to be talking about is ubrogepant. So basically, it's a competitive and potent selective and orally administered small molecule CRGP receptor antagonist. And it showed that it's very specifically highly potent for the human CRGP. So the study is called ACHIEVE, and basically what they did, they gave the patients a placebo and the medication, and they had the visit 1, they screened the patients, and then in visit 2, they gave them the medication, and then within 48 days, they had visit 3. And it's usually 2 to 7 days for each participant from their initial dose. And basically, they gave also an optional second dose of the study medication and rescue medication dosing, in the sense that within 2 hours of the initial dose and up to 48 hours, if the patient experiences inadequate response, they can take a second dose of the medication or a rescue medication. Definition of an adequate response: if they still continue to have moderate or severe headache, and they don't have initial, or they have moderate to severe headache that returns within 2 to 48 hours after little pain relief. So the pain freedom means complete resolve of the pain. This is the co-primary efficacy endpoint, and the pain relief, which is decreasing the disability of the pain but not taking it completely away. 2 hours post-dose met its primary endpoint with flying colors, as they say, as you see the difference between ubrogepant and placebo. For both of these 2 endpoints have been chopped by at least 50%. We see 11% here and 21% here for the 2 pain-hour pain freedom. And for the pain relief, it's almost 2/3 of difference. So the primary endpoint, the absence of migraine bothersome symptoms at 2 hours post-dose, it met it with a good degree of confidence. As you see in the placebo, only 27% compared to about 40% in the ubrogepant arm. And just to highlight, both doses, 50 and 100 milligram, has showed that they are more effective than placebo. So the adverse events that were related with ubrogepant against placebo are very, very, very comparable. None serious side effects have occurred. The only things that to notice is nausea. And in any migraine study, I always tell the patients, you never know the nausea is from the medication or from the migraine itself. So I can't take that with at face value. Some of them complained of somnolence and a little bit of dry mouth. Otherwise, it was very, very tolerated. And talking about the risks, we have to talk about the cardiovascular risks, since we're comparing them to the triptans. In the post hoc analysis, they classified patients into 3 categories, where they have moderate to high risk, or they have low risk or no cardiovascular risk. And basically what they found is that in all treatment population, the treatment-related side effects were not significant at all. So we have no issues in prescribing them to people with cardiovascular issues, because, as I said, they work postsynaptically, not presynaptically. So the early intervention with the GPANs, it helps in the study that was, it was proven in the study that's called Prodrome, that the earlier you administer the medication, the better you will have of bothersome symptoms relief. So basically, they had a screening period where they record at least 13 to 16 qualifying prodrome events. And in the first prodrome event and the first rome, sorry, they had a switch over. Basically, they have the group A and group B, and they gave him placebo and then Obrigepant, and then 7-day washout period, and then they switched them over. And basically, it showed excellent results in showing that there is moderate to severe intensity headache within 24 hours. With Obrigepant, 45% were treated as opposed to 28% only in the placebo arm. And the secondary endpoint, which is the absence of any headache of any intensity within 24 hours, is also almost double the amount. Again, the safety and tolerability of this study, which had over 900 patients, was excellent. None of them had any serious side effects. Moving on to the real-world evidence, the COURAGE study design, this is a very beautiful prospective study to show the effectiveness of Obrigepant with either a CRGP monoclonal antibody that is preventative, or Obrigepant with Botox, basically. And what they did, basically, they took adults with migraine, and they had their inclusion criteria, as we see it on the left-hand side, and they screened them for eligibility. They did the baseline collection of the MIDAS PHQ-4 for their possible depression, and then the final assessment. And it shows the efficacy results are here. Basically, the achievement of meaningful return to normal function after the first treated attack was way higher in 2 hours post the first dose and 4 hours post first dose. And return to normal function was pretty high as well, achieving meaningful pain relief and return to normal function across 10 treated attacks. And this tells you about the sustainability of the treatment was excellent. And I honestly, when I was a resident, I never thought I would see those numbers in a study, especially with the combination therapy. The same thing goes with the injected CRGP monoclonal preventative therapies. You see a 2-hour post-dose excellent response of patients. 80% will tell you that they have meaningful pain relief, and more than half will have return to normal function within 4 hours. And achievement of meaningful pain relief across 10 attacks, 70% and 50% for a meaningful pain relief and return to normal function, respectively, achieved that. This is miraculous for migraine, in my opinion. So the preventative migraine landscape, as we know, it's quite wild, and as it was mentioned in the previous talk before, you always look at the specific patient's profile and their side effects. And the problem with the non-specific oral ones, they're not specifically developed for migraine, so they have a lot of side effects, sometimes that are wanted, like the amitriptyline. We want the sleepiness, but sometimes in amitriptyline, we cannot tolerate the weight gain or the dry mouth. So it's something, a double-edged sword. But definitely, in the last 5 years or so, we had a breakthrough in the migraine-specific preventions, whether that's an injectable thing, such as an IV eptinezumab, or oral, such as the rimegepant or atogepant, or the injectable sub-Q, which are usually taken monthly. And of course, the injectable, which are taken every 3 months, is the Botox, which also works in 2 different ways, blocking the CRGP locally and also with smooth muscle relaxations and affecting the trigeminal nucleus as well. The impact of treating early within a patient journey, it's clearly stated in different guidelines and and policies that, for example, in the European Headache Federation and the American Headache Society position statement, that CGRPs should be considered as a first-line approach for migraine prevention, along with the previous first-line treatment, without the requirement of a prior failure of other class of migraine preventive treatment. And this is exactly where I stand. That I would suggest even the CRGP's pathway to be included as a first-line option due to the very, very friendly side effect profile and very highly clinically efficacious from data and real-world experience. And we all know that patients usually
is being recorded.
Patients, most people with preventative medications, one of the problem is the discontinuation. The discontinuation rate, it has been noted in things like the atogepant and the other injectables to be much less. And for example, in this study, the on average 7 out of 10 responded would select a profile like a once daily Gepant over like a class of monoclonal antibodies. And this is taken at least from one study. So what is new with the new preventative therapies in the Gepants? It's the atogepant. What is the atogepant? It's just like the obrigepant. It's a small molecule. It's a CRGP receptor antagonist developed specifically for the prevention of the migraine. It's not for the acute therapy. It's designed to minimize the potential risk of having exometabolites that are seen in others. This is the recommended daily dosages. It needs to be adjusted with if they're taking concomitant strong CGPY inhibitor or they have severe renal failure. So the recommended daily dose is 10 milligrams instead of 60 milligrams. So the pivotal clinical trials that made this possible is the advanced trial for episodic migraine and the chronic migraine, the progress trial. And also, basically, it showed long-term safety and tolerability along 52 weeks. And then in a 40-week extension trial for episodic migraine, the same thing has shown. And basically, if another study was also done, if they have failed 2 out of 4 classes of oral prophylactic treatment in the Elevate trial. And they also done it in in a long-term safety tolerability in chronic migraine. So across all of these studies, the atogepant 60 milligrams and 10 milligrams showed significant difference in treatment, in regards to placebo. And this is basically the days of migraine headache that has significantly changed from 2.5 to they decreased from they had, instead of having 2.5 less headache days, they had 4-5 headache days. And the secondary endpoint that was found in the migraine of average. No, sorry about the sound.
No problem. It's okay.
Okay, I'm just closing my computer as you speak. Okay, I think that's fixed. So the advanced trial basically showed that the treatment-related side effects were excellent. And basically the primary endpoint, as I said previously, it was met, and the secondary endpoint having more than 50% reduction in the 3-month average migraine days was significantly higher in the atogepant compared to the placebo. So that tells you that we have a clear sustained effect along the course of at least 3 months. And this is also something that we have only seen maybe with Botox and things like that, but none of the old non-specific treatments. The Progress chronic migraine trial basically around 9% of all randomized patients has completed the study. They used 2 doses, either 30 BID or 60 once daily, and they followed them for 12 weeks. And the change from baseline and the mean monthly migraine days has significantly been reduced by from about 7. They had 7 reduction days across compared to 5 reduction days. So the relative reduction is not mild here. And they have a rate of over 50% responder rate along the 3-month duration. The adverse event, most of the patient complained of constipation and a lot of nausea. Treatment-related adverse effects were not that significantly higher in the treatment group, and the something leading to discontinuation was very comparable between the 2 groups. So again, the most common adverse effects were predictable and were consistent, and the safety profile is shown that to be favorable in the atogepant. This is a longer-term safety study over 52 weeks of atogepant of 60 milligram per daily. And again, the constipation and upper respiratory tract infection were the highest related side effects. And there is nothing really that came out as treatment related that is specific to the atogepant. So the tandem study, this is the last thing I'm going to touch bases on. The tandem study was done to study acute and preventative GPANs taken together. This is, of course, it's not recommended, but what they did was it's a multi-center phase 4 2-period open label study in the States. And they used subjects were screened. They included 236 patients, and basically it's to evaluate the safety and tolerability of the obrigepant and atogepant administered concomitantly. Basically, those are patients who has been using atogepant as a preventative treatment in the and for about 12 weeks in period 1. In period 2, they used atogepant and obrigepant as a rescue therapy. And basically, the common treatment side effects have not shown that there is any significant safety red flags here. The things that were more significant in the population group, not really much, as in compared to the treatment group or the initial group who were treated only with atogepant. So I dare to say if it's probably safe to prescribe. It's not safe. It is proven to be safe to prescribe atogepant and obrigepant as a rescue therapy. So in conclusions, we have acute therapies. There are specific and there are non-specific medications. We have the GPANs, which are extremely specific and very favorable, low side effect profile. And one of the things that I would encourage all of you is not to be hesitant in prescribing the GPANs. I know they're new. The monoclonal antibodies and it might be a little bit concerning for people who are not used to seeing patients with migraine to prescribe it, but I want to assure you that at least getting yourself familiar with one GPANT or and trying it with your migraine patients, and if that doesn't work, you can refer them. I think this is a better approach for the patients, for us, and for you. Then we have the preventative medications. Again, we have the non-specific medications. We have Botox, which is specific and non-specific, in my opinion, and monoclonal antibodies, and the GPANs. So these are basically the barcodes if you want to get the full pamphlets of the Obrigepant and Atogepant. And I'm very extremely sorry about the technical issues and the delays. I hope the talk was clear.
Yeah.
And
Thank you so much, Dr. Hisham.
Thank you.
It was very clear, very informative, and very encouraging as well. You ended your presentation with encouraging the primary care physician to take the opportunity to use the GPANs as part of our day-to-day clinical practice. And I think now we are living in an era where the primary care physicians have moved to another level of performance with the new competencies. So we're not dealing with a very simple common problem, but also with a highly complicated yet challenging clinical entities like migraine. So now we have mastered how to prevent, how to tackle and manage the acute episodic migraine, and how to prevent the migraine as well. So thank you very much for your informative presentation, Dr. Hisham. And I think it's now to open the floor for the audience to receive their questions. In fact, I received a couple of questions, in fact, from both of you. So we'll start by Dr. Saeed. Dr. Saeed, thank you for the presentation. It was really clinically implemented to touch base the real scenario of our primary care setup. So the question is, when should preventive therapy be initiated rather than relying on acute treatment? So this is one of the very common problems that in primary care, we just keep on treating the acute episodic migraine. We never think about going towards prevention. So what is your clinical recommendations and experience? What time is the appropriate time to start the preventive on top of the management of acute episodic migraine?
Yeah, thank you for your question, doctor. Yeah, this is a really important question, and we face it at the clinic. Here, it is not about the number of the attacks, because we need to measure the disability, as we see in the slides. So if the patient have 4 or more attacks, I can discuss that with him. But what if the patient have fewer attacks, but the attacks it continue for longer period, or have a severe disability, the patient misses his days of works? Here, I will discuss also the preventive treatment with the patient. Another issue is how difficult to treat the acute attack, because sometimes it's difficult to treat the acute attack, so I need to go with the prevention. If the patient trying to get pregnant, so not every acute treatment can be given to her. So at that time, I will discuss the prevention. Also, the patient preference. This is a really important point. So when I put all that together, yeah, if the patient, even if he has low frequency but major disability, I will discuss absolutely the prevention for the prevention option with my patient.
Excellent. Well said, Dr. Saeed. But let me just continue the same question. What is the perception of patients once you advise them to try the GPANT for the first time? Are they reluctant? And what is their perception after using it, and getting the relief? This is one point. The other point, what is your challenge that you encounter with insurance companies to approve these medications at the level of the primary care? So give us this kind of sense.
Absolutely. First, mashallah, now I see a lot of patients came asking about the GBANT. So now the awareness and the easy to get the information and to discuss with your family physician, I think this is something common now in our clinics. Sometimes because the patient afraid this is a new treatment, But when we see the safety profile, and as Dr. Hisham mentioned, it's yani reassuring, and especially when I am talking about medication that is really very effective treatment, especially if I have the option, because some patients prefer the injectable because it's more convenient for them than the daily tablet or every other day tablet. And some other patient, they afraid of the injection. So the concern is there any oral treatment from the G-band? Yeah, and this is how to tailor the patient prescription. So we face it, and sometimes you need to discuss the patient, discuss this prevention of or this kind of treatment with the patient, and the patient read about it and comes again to have a deep discussion about these options. Also, for the second question for the insurance, and that's why, and thank you for Dr. Hisham for saying that we can start as a first line the G-band for some patient, especially the cash patient, because the insurance need to follow the criteria or the guidelines. As I know, until now, there is no guidelines recommend to start the G-band as acute treatment. But for the preventive treatment, yes, some guidelines consider it as the first line, but you need to justify it clearly to your insurance or to the insurance why we are using this kind of treatment. Also, I think now the expert going with their opinion to start even this G-band for the acute treatment. But until now, as I know, it is not recommended by guideline, but yeah, we are toward this pathway.
Thank you so much, Dr. Said. Dr. Hisham, from your clinical experience, what is the best candidate for the anti-CGRP therapy in the current clinical practice for primary care? So what is the profile of patients? There is a recommendation that we can start G-PANT, but again, what we have used to do, we start by the NSAID and then triptan, and then we go all the way to the G-PANT. So how do you describe the best candidate for starting G-PANT?
G-PANs. So I would say the two available ones in Saudi here, and they can be used interchangeably. If one doesn't work, the other can work. I've seen it in a lot of patients. Is either using the Ubrigepant right off the bat, even with the NSAIDs, especially if, and I tell the patients, from the first go, I have actually a pamphlet telling them that you can use acetaminophen, NSAID, and a G-PANT.
Mm-hmm.
All of those three together, or some of those two, or one of those two. So I would usually tell them use Ubrigepant, and they can take another one after 2 hours. If they have, sometimes it doesn't work, or if sometimes the nausea is the first symptoms and it's pretty severe, I prefer to give them the Rimegepant because it's an orally dissolvable tablet. It's put on the tongue and gets dissolved. It's called Rimegepant, and it can also be used as a preventative as well. So yeah, I would go ahead, prescribe one of those two. And if those patients from your end come to me and they say, well, we've tried Ubrigepant, it didn't work, you cut half the time for me and the patient.
Yeah, absolutely. Absolutely. But you said, Dr. Hisham, that we don't have to wait for the failure of triptans,
No.
or so we can start by the G-PANT. Yeah, this is a very solid statement, and it was recommendations of some of the guidelines and authorities. So how this is applicable in our current clinical practice?
So in the current clinical practice, given I think we're going to have a little bit of difficulties and challenges that we have to come across, and having such seminars, webinars, is the first thing to do. It is the awareness of the physicians themselves about the availability of these medications, that they are safe, and actually, one point I just want to mention. From the initial point when we talk about convincing the patients, and the patients, they have an issue that this is a new medication. Well, I tell them, yes, it's a new medication. but I compare it to the older one, and the older one has a worse side effect profile.
Absolutely.
And this is the selling point. This is a selling point for the patients themselves. The
Yeah.
other thing is that showing the efficacy of the patients. So in our, I think the clinical practice has to change first by the family physicians. To be honest, the family physicians have to be more encouraged to at least suggest it to their patients, so the patient can do their own research if they wish to. And the family physicians, as I said, should be at least aware or comfortable with one of the medications, just like the triptans. I'm sure most of if family physicians have one triptan failure, they would tend to send this patient to another neurologist to do, and they wouldn't feel comfortable switching over and over between triptans. So the same thing goes for GPANs, I think.
Yeah, I totally agree. And I share with you my experience as well in GPANs. It's phenomenal. It changed dramatically the quality of life of patients, and patients pay out of their pocket just to secure this improvement in their quality. And the perceptions of the recovery and the better quality of life can be perceived as fast as we can
Yes.
think. So, but again, Dr. Hishami, you mentioned about the efficacy, which has been highlighted in the studies, and the durabilities and the patient acceptance, but the safety. Did we have enough long-term studies to secure the safety, or still we are confronting with the reality that
If we
in
look
the
at the
future we might.
data,
Mhm. Tafadhal.
I definitely. This is, I mean, we all know in certain periods it takes few years to find a certain link between a medication and something. However, the pathophysiology that these medication work on, they are more selective, and they don't have usually there is no reason to think, either with the big number of trials. They had patients, over thousands of patients, and some open label extension up to 52 weeks. That's give me a migraine study that had 52 weeks of follow-up. No, there isn't. And then we have the anecdotal evidence. I have patients who are on these medications for 3 or 4 years, and I think they're overused by the pamphlet. Even the pharmacists are telling me so. Walillah alhamd, I haven't seen any undesirable side effects so far. So just by the pathophysiology, it's not something that has been shown, that it's not something that changes the CRGP, or the how the CRGP is being initiated or anything like that. So and the one thing to reassure you, in the trials, they measure the CRGP levels. So they know that the CRGP level, they peak during the migraine attack, and these medications, they actually bring it down.
Yeah.
And even if they don't bring it down, they block it from the trigeminal nucleus. And this is why we believe that it's ratherly safe, because if you look at the triptan trials, the initial triptan trials, and you look at the side effect profiles, or the ergots and the side effect profiles, they were more harmful than the
Yes,
numbers that we are seeing now.
absolutely. Well said. Dr. Saeed, in the primary care, we have a lot of pitfalls and mistakes, and I would like to highlight it to make it this kind of discussion more useful to our colleagues in primary care. What is the most common mistake leading to medication overuse headache, and how we can prevent it? Of course, we are using NSAID a lot, tryptane a lot for a long period of time, and this creates this kind of problem. So, what do you think from your perspective, what are the mistakes and how we can prevent it?
I think the
I'm sorry,
first thing is to ask the patient about the medication use itself, because sometimes with the basic clinic and the patient come for the refill, you need to just ask the patient how many tablets he takes. This is the first thing, is to identify it. Sometimes it's difficult if you and you didn't have the scheme to ask about it. Then it comes to convincing the patient to change to other better treatment, because without any explanation, if you tell the patient you will remove this medication and you will go to preventive treatment, the patient will be hesitating. No, I feel now with the medication, I have this kind of headache. What if I stop that? And this is the problem. Also, when you explain to the patient, it could have some worsening of the headache at the beginning, and then everything will goes better. He is expecting that, and this is not something wrong. This will happen. This is the part of the course, and we will have other alternative, and inshallah you will feel better after that. So the good communication and the identification, I believe, the first important steps. After that, the good plan and a practical plan could help the patient to get from this overuse of medication.
Thank you. Dr. Hisham, just to continue the same question, do you recommend certain days to be used for NSAID and certain days for triptans? Yeah.
So this is by the ICAHD International Headache Classification. So for the acetaminophen, it's 15 days of headache per month. And for the NSAIDs and the triptans, it's 8 to 10 days. It's usually, I quote it at 8 for the patients, because you put it at 8, the patients will use 10 probably. One of the things I just want to add on here, there is a trial, randomized trials called the MODS trial. It showed whether if stopping the medication abruptly is better or doing it gradually. It didn't show significant difference between the two, except the ones that were abruptly stopped, they had more, they had a little bit more recurrence of using the medication and more headaches. So that's why in my practice, I don't stop the medication. If they are overusing paracetamol, I don't tell them stop it. I tell them if you take one paracetamol today, for the next 5 or 6 days, you don't take it. So I decrease it by 25%. This gives the patient, as Dr. Sayed said, is that they will feel comfortable that they have their medication, and it helps a lot in reducing it, and offering them an alternative is the best way to go. Sometimes you will find a patient who's having 2 medications that he's overusing. Here it gets a little bit more complicated. I can put them on a course of rimegepant or a little bit of maybe amitriptyline for a while, and it reduces the MOH. But definitely the MOH is one of the nastiest things that I see in my clinic that the migraine patients come along with.
Absolutely. Dr. Hisham, when do you think that we could consider switching between different GPANs and combining GPANs with others for prevention or even for acute episodic migraine?
From the get-go.
If there is any, if there is any specific criteria to go stepwise?
You mean in regards to treating the in terms of prevention or acute therapy?
Prevention, for example, when we switch.
So I usually do the switch if the patient is feeling that there is a, for example, in galcanezumab, an injectable one, I find a good number of patients have the treatment effects start to get less after a while. So after a year or so, it's not as helpful. So in that case, I prefer to switch them unless they have a strong reason to be on it. The other reason sometimes because of insurance issues. The other way to do it is basically sometimes I would use a conventional, and this is actually not a small number of my patients, but I do use a conventional and GPANs or a monoclonal antibody. And I do that because a lot of the patients will benefit from treating the side effects or they will benefit from the side effects of the medication, namely the amitriptyline. Amitriptyline will fix the sleep hygiene. It will fix the headache. And I think it's one of the medications that is way underused here, and it's pretty safe. And combining that with a GPAN, sometimes it's very helpful. In regards for the acute therapy, I've seen a lot of experts, and I have done that as well, prescribing both at once and telling the patient, try this and try that in 2 different attacks and see which works better for you.
Okay, very good.
Does that answer the question?
Yeah, excellent, excellent. If you would like to forecast where you will be positioning, where do you position the gepant in the future? Is it going to be the dominant anti-migraine medications for acute episode and prevention?
Yes.
And what will be
Yes.
the fate of triptans, for example? Is it going to be obsolete because of the side effects, because of the cost and tolerability and so forth?
Exactly. So the I think the conventional medications are here to stay because they are cheap, they are effective, and in a lot of parts of the world, you'll not find the hot new G pants because they're inaccessible to a lot of patients. But I do forecast that in the near future or the immediate future, the G pants will be a if first line for both preventative and both the G pants and the monoclonal antibodies, by the way. Both of them, I forecast them to be a first line therapy. Why?
Perfect.
Because even despite their price, migraine is still the leading cause of disability or the second leading cause of disability worldwide.
Mhm.
This is the financial waste is huge, huge.
Yeah, more than a million, billion, 1 billion people across the globe.
It's unbelievable. It's unbelievable. And
Abs-
to the point of when do I start prevention? I honestly start prevention because whenever I ask the patient, are you willing to lose 3 days of your month, 4 days of your month? And they say no. I say,
mm,
okay, we'll start prevention.
Okay, perfect. طيب, Dr. Saeed, in primary care, we go in a full passion to treat patients with migraine, but still we have to put certain limitations for our scope of service. So when do you refer patient to Dr. Hisham, the neurologist?
Yeah,
So, uh,
this,
uh,
this, this
yeah,
happened actually. Yeah, if the patient, some patient actually have a severe migraine or chronic migraine. Sometimes these patients are difficult to treat. So I use the referral to my colleague at the neurologist to see if they can, if we can have a shared management with them so we can treat the patient. Also, as Dr. Hisham said, sometimes the medication overuse headache patient have some difficulties to treat them. So we need for some patient to just have the neurologist with us to help the patient.
excellent. Like, okay, so let me just rephrase the coming few questions to be more generic, to
Mhm.
highlight the issues of the unmet need in management of migraine. So how we can reduce the diagnostic delay of migraine in patient here in Saudi Arabia? It's for both of you, Dr. Hisham, Dr. Saeed. So how we can, there is a therapeutic inertia and there is a reluctancy to manage patient with migraine in spite of all these medications. And even most of the time, primary care physicians confuse migraine with other types of headache. So they get nowhere, doing the right thing for the patient. So how we can be more aggressive in managing the patient right in time in early stage and early period of migraine يعني attacks. دكتور
So,
سيد go ahead.
sorry, تفضل دكتور سيد.
تفضل.
تفضل. طيب والله أنا هقول أول حاجة the first thing is to overcome the physician inertia itself because I believe the more percentage is from the physician himself. So we need to have like this seminar discussion and we need to involve more the primary healthcare physician to use this treatment because as Dr. Hisham said, I think some physician, if they don't try this medication, they will be afraid to use them. On the other hand, if we see the safety profile, no, you can use this treatment and they are really effective. And especially in this era, we have a lot of options now. So first thing is to have a good uh, a physician with more information about and more experience how to use this treatment. And thing is also to have the correct diagnosis from the beginning and not let the patient suffer because the migraine is not diagnosis of exclusion and it's not need any investigation usually unless there is a red flags. So we need to start and focus on primary care. And I believe, yeah, the primary care physician can take a lot of cases of migraine and manage these patients.
Okay, thank you. Dr. Hisham, تفضل.
So I completely agree. I echo everything that Dr. Said has said, but I think also the journey starts from the patients themselves. The patients starts on the journey themselves. Most of my patients, they are referred for ENT. when they go there for sinusitis, they يقول عندي جيوب أنا من زمان بعدين ما طلع عندي جيوب. So I think having more يعني nationwide awareness campaigns is probably the first and the best thing to do. And having those kind of seminars will decrease the diagnosis. Secondly, I think developing certain tools which are backed by evidence, which makes it easier for the family practitioner to diagnose migraine, in the sense that instead of him memorizing the whole criteria, doing a small little tool of whether the patient has a headache, yes or no, yes or no, yes or no, and filling up the questionnaires. And well, yeah, it will give you the probability that this is a migraine, definitely that this is a migraine, no, this does not fit a migraine. So a lot of institutions, and I think some nations have adopted that, and it did decrease the delay to diagnosis by a significant amount.
Excellent. And I echo all what you have said. We start by the patients, because many of patients, they don't realize that this is a migraine and it's treatable, so they don't approach the medical professionals right on time and the stage. This is one arena. The other domain is the physicians themselves. We have to tackle the therapeutic and clinical inertia by educating the physicians. But the third domain is the healthcare system. We have to have a clinical guideline that brings the patients across the board between primary care and secondary care, so the patient will move smoothly between the two levels of care without any kind of turbulence, addressing exactly what the patient requires and going all through the new modalities of the treatment with full confidence. So I think this is the way. And this will bring us to another important question, Dr. Hisham and Dr. Saeed. What is the ideal collaboration model between the family medicine and the neurologist in migraine care? How you can build this kind of relationship, this model that has to be smoothly built to have a clear pathway for the patient to move between these two levels of care smoothly without delay. Dr. Hisham,
So I think, as I said, developing a clinical tool or a technological tool where you can put your patient's input, knowing the criteria of the migraine itself, and recognizing it is the first thing to do. I see a lot of people do shy, even whether it's family practice, general practice, or other practices. Whenever a patient would say, "I have nausea, vomiting, and headache," they would be terrified. They would go see a neurologist right away. So I think what's common is common, and we should collaborate more by knowing that most of these patients will end up in non-neurologist clinics. In the beginning, they will end up in the GI, ENT, family practitioners, and developing, I think, a nationwide pathway, or at least guidelines by a yes or no algorithm that helps stratify the patients. Do these patients still need to be seen by neurologists? Is this enough? Is this not a migraine? There is some red flags. I think this is the way to start with.
Absolutely. And I think one more point, Dr. Hisham, is the feedback from the neurologist back to the primary care physician. It's very important to make sure that the diagnosis was appropriated right and the referral was optimal to move the patient to another level. So this is where the physician, the primary care physician, can maintain the continuity of care, because finally the patient will be landed in the primary care to have the full spectrum.
The problem with this, Dr. Ashraf, is unfortunately the feedback loop. We don't have this in Saudi. We don't have it yet between the primary and the secondary.
Yeah. But in a tertiary hospital like what we have in IMC, for example, we have both primary care and secondary care. So through the system, we can visualize everything and the patient will move smoothly. Any thoughts, Dr. Said?
Absolutely, yeah. I think I'm totally agree with that. The thing is, we need the family physician to refer the patient correctly to the neurologist. Not every patient with migraine, a lot of patients with migraine, actually, they don't need the referral. And also, when they have the referral, the neurologist, I think it's really nice to get the patient back to family physician to follow up with the family medicine clinic. So in this way, I think, yeah, we will have a good collaboration also.
Okay. I think we're coming to the end because there is a lot of questions, but it's repeated questions. So I would like to end by the $1 million question for both of you. So if there is one statement you would like to deliver it to the primary care physician to change their way of managing patients with migraine appropriately, accurately, and to yield the outcome, which is improving the quality of life patient, what would you like to say? So this is a take-home message for the physicians to take it tomorrow in their clinical practice. دكتور سعيد تفضل.
تفضل دكتور.
طيب دكتور تفضل دكتور هشام.
I would say learn the migraine criteria. Don't be afraid to familiarize yourself with the new medication and try it for the first time by yourself.
Excellent. Excellent. Well said.
Yeah, absolutely. And I think the take-home message now, try to diagnose the migraine as early as possible so the patient will not suffer, especially when we have a good option to treat that.
Absolutely. Well said for both of you. So I would like to say the same. So early diagnosis of the case, we have been set in a very important position as a primary care physician to be in the gatekeeper, to be first contact with patients. So we are positioned crucially to manage the patient or to diagnose the patient and to identify those patients at risk of having migraine. So we can initiate those tools of diagnosis early stage and then manage them appropriately, because now we have been privileged to have multiple medications with the smart molecules like the GPANs on the table. So we can use it with a full confidence. It has been proven to be efficacious, safe, durable, and patients are accepting it very well. So with this, I would like to end by saying it's not all about working hard. It's about working better this time. So let's work better and carry all what we have learned today with the wonderful presentation of the two guest speakers, Dr. Saïd Al-Amoudi, Dr. Hisham. It was marvelous. It was rich presentations and rich discussion. So on behalf of all the audience, I would like to thank you, Dr. Hisham, Dr. Saeed, for your contribution to this wonderful gathering. And I would like to thank Avi for giving us this wonderful opportunity to be together. Thanks for Multaqa Al-Khibrat for organizing this wonderful event. And to all of you, ladies and gentlemen, for being with us here for the last 2 hours. MashaAllah, we have almost 750 attendees. And I hope what we have delivered was quite appealing and encouraging all of you to carry the responsibility and do something better for our patient tomorrow onward, inshallah. Thank you so much. Jazakumullah khair.